Hi all, I'm Dr. Angeline Raju, an internal medicine resident in Texas Health Resources, HEB and Denton. Today, I'm going to present an interesting case report of chronic occupational exposure to organophosphate with evolving basal ganglia pathology. Organophosphates are widely used as pesticides, industrial chemicals, and even nerve agents, making them a common cause of poisoning worldwide. This case report underscores the importance of recognizing the insidious progression of organophosphate poisoning and its potential to manifest with diverse neurological symptoms. We present a 57-year-old Hispanic male with an episode of syncope while at his workplace. He is a pest control technician and had 7-year history of exposure to organophosphates. He had a history of frequent falls over the past 6 months and had no exposure to other toxic substances, alcohol, or drugs. Physical exam was consistent with resting tremors and ataxic gait. Further, workup with a CT head revealed internal capsule enlargement and edema within bilateral basal ganglia without signs of hemorrhagic transformation. Subsequent MRI brain indicated an interval worsening of edema and abnormal signal involving bilateral basal ganglia with new involvement extending to the cerebral peduncle. Additionally, a new finding of restricted diffusion was noted within the medial aspect of globus pallidus, suggestive of necrosis compared to MRI done 2 weeks prior when he was being evaluated for slurred speech and confusion. CSF analysis was performed to rule out infectious, autoimmune, and paraneoplastic etiologies, and the results were unremarkable. After discussion with neurology and radiology, it was determined that the patient presentation was consistent with basal ganglia involvement due to chronic organophosphate exposure. Over the course of admission, he showed continued clinical improvement and was eventually discharged and advised to avoid organophosphate indefinitely. Discussion: Organophosphate exposure has been associated with various neurological effects including tremors, ataxia, slurring of speech, and basal ganglia involvement, which is very similar to the Parkinson's disease. Acute organophosphate toxicity is well documented and is characterized by initial acute muscarinic symptoms followed by the nicotinic phase. In contrast, chronic exposure often eludes timely diagnosis and appropriate management as no cholinergic symptoms are seen. During his hospital stay, the patient's clinical improvement was solely attributed to the symptomatic and supportive treatment and, more importantly, cessation of exposure to the organophosphates. In conclusion, this case underscores an intricate interplay between occupational exposure, neurological manifestations, and the radiologic findings. Learning points: this case report emphasizes the significance of occupational history taking, considering the toxic exposures, collaborating with other specialties, and promoting health and prevention. Recognizing that the improvement of symptoms can occur with further avoidance of toxic substances serves as a valuable teaching point. Hope you enjoyed. Thank you.